Hi, I'm Dr. Salil Kandwala, and today we'll be talking about the management of stress urinary incontinence. So we already reviewed the anatomy, but a quick primer. So the front, back, top, bottom, the bladder is here, urethra, vagina, uterus, and rectum at the back. So stress incontinence happens as the bladder is filled up, the urethra is here. Now, if the urethra tends to drop back, funneling it open results in stress incontinence. We've completed the history forms that we have reviewed. We did the examination in the lying and the standing position. We did the urodynamic testing, looked inside your bladder, and you've also brought in your avoiding diaries. So now that we've seen the 24-hour diary and the 3-day diary, let's go over the treatment options. Now, the first step is always behavioral therapy. That is very important, diet and exercise. So behavioral therapy is, as you can see in the 3-day diary, this patient is hardly going. She's going at 7 a.m. and then at 1 p.m. and then at 7 p.m. So because she's not going that much, she's holding a lot of urine in her bladder. And if she coughs, then she leaks. So all we needed her to do is just go more frequently. Same thing in this case. See, she's again voiding infrequently right here, and she's having coffee, which is a bladder irritant. So if she goes more frequently and avoids coffee, that should help with the bladder stress incontinence. That's the beauty of doing the voiding diaries. It can help us with a simple thing. Now you don't need any surgery or a procedure. You can just take care of your fluid management. Pelvic floor physical therapy is done by a physical therapist, and it is in our office. We have a physical therapist. The aim is to strengthen the urethral sphincter, and that is done with a machine that helps contract that urethral sphincter and makes it stronger. And it's done in the office weekly for about 4 to 6 weeks. From the surgical management standpoint, a lot has changed. Even though people and my colleagues are still talking about bladder suspension, I have not done a bladder suspension for almost about 20 years. It required an abdominal incision or laparoscopically, where you're lifting the vagina and attaching it to the pelvic sidewall. 1990 saw the evolution of the mid-urethral slings when the TVT sling came about that opens up into the lower belly just at the level of the pubic hair through 2 small incisions, and then the transobturator sling that opens up into the groin. So these are long slings, they're called. But then came the single incision sling in 2006, and I was the first surgeon to use the single incision sling that was made through an incision, just about a centimeter incision in the front wall of the vagina. This is the Solix sling that I'm using at present. It has these tiny little plastic anchors on each end, and those anchors basically go into the muscle under the urethra. As you can see, the urethra is right here. The sling goes under the urethra, supporting that urethra, and attaches to the muscle. So now if the urethra tries to fall back, it gets a nice little backstop. So here it's trying to fall back, and now you have a nice little backstop of that sling made of polypropylene, and that supports this urethral tube and maintains continence. Despite that, what was seen is that the long sling still enjoyed very good results, and the single incision sling in the majority of hands were not doing that well. So then I came about with a technique change called DIST. So as you know, most surgeries are done with the patient laying on the table under anesthesia, but women don't leak lying down, they leak standing up. So the ultimate test is for the patient to stand up and cough. But if she's under anesthesia, then that can only happen after the surgery, and it may be a little too late. So a sling that looks good to the surgeon during the procedure may not be good enough for that patient. So when we have these poor results with a single incision sling that have been reported in the literature, and they may say that, oh, that sling becomes loose, or is it that the surgeon did not place it tight enough in the first place? So what I came up with is this harness bar and the platform. So if looking from the side, you can see this is the harness bar that I worked with an engineer to work on. And then this is a table that goes up and down. It can withhold almost up to 500 pounds. So it's a very solid table. So first we have the OR team who's all scrubbed and ready. Then we have the patient coming in. The nurses in the preoperative area will apply the lidocaine gel to the vaginal opening, which is right here. And then I begin the procedure. So you're placed in the dorsal lithotomy position. I'll make that incision under the vaginal wall, and we'll place the sling under that, and you're completely awake as you're doing it. Then we'll fill the bladder up, make sure the bladder looks okay, fill it to your capacity, which is confirmed with the ultrasound. And then this is the most important thing. Then have you stand up. You see how you're holding on to that handlebar? You'll be standing up on that platform as I'm looking with my light. So now I'm looking at the urethra right there. So you're standing up, you have a full bladder, and you're coughing, and you have no leakage at all. If there is any leakage that I see, then I'll tighten that sling because I still have that instrument in my hand. I'll tighten it until you do not leak anymore. That's called this success. So we have published the results, and we saw 97.4% with no complication. And then same thing, about 94 to 95% was satisfied without any complication at the 2-year mark. And recently we did a 3-year evaluation of women who had it done in the office under local anesthesia with 95% cure and no complications. So bottom line is we are enjoying a cure rate of 95% when the other studies with the single incision sling were showing about 50 to 55%. Even if you consider what's considered the gold standard, the long slings, they had a success rate of 85%. And in our case, there was no complications, no bleeding, no erosions. Now you compare to the bladder suspensions that I used to do over 20 years back, their success rate is 19% over the long term. You see, so the complications of these long slings do exist. There's about 4 to 5% risk of injury to the bladder with the TVT, and similar 5 to 6% incidence of groin pain with the groin sling. Whereas with this, we have no pain, no complications with the single incision sling, and very high success, mainly because of my technique. This is the game changer. Sling, full bladder, stand up, cough, no leak, instant confirmation. Nothing is left to chance or surgeon judgment. It allows for immediate intraoperative adjustment. So if you leak, I can tighten it right there and then. Once you go home, it's too late. Instant confirmation of success that sustains over the years. So it is no one-size-fits-all concept. Everybody's weight is different, their intensity of cough is different, their pelvic architecture is different, and their urethral weakness or no weakness could be present. So there are many factors that could affect it. As one of my patients very nicely told me, it's almost like a bridal dress. One size does not fit all. And even for that same person, the bride, she has to come in for the dress fitting and possibly may need alterations. It is a once-in-a-lifetime event. You don't wear this again. It's a once-a-lifetime dress. But just like the sling, do it right the first time and you don't have to do it again. It's done under local anesthesia. It takes about half an hour to perform. Most patients are home in an hour. There is minimal pain, if anything. No prescribed pain medications are given. You can return to all activities the next day without restrictions. So as my patient told me, it's like a drive-through sling. You come, get it done, and you go home. All medical societies, you may have heard of sling and mesh in the media, but all medical societies, not just in the US, but international too, state that the material, the polypropylene of which the sling is made, is inert and safe. Slings are safe and effective, and they are the most studied. In our hands, our complication rate, I can't even tell you, it's less than 1%. Difficulty emptying the bladder can happen in 1 in 6 women, and that is because the bladder may get too numb from the local anesthetic. You may have got a lot of fluids during the procedure. So you may need a catheter maybe for a day or so, and then you come to the office, it's removed. Long-term catheterization is very rare, and release of the sling also is very rare. Exposures of the vagina are also very rare, and pain for the partner is rare. So I can tell you that typically it's less than 1%. In our 2 most recent studies, we had no complications. After the sling, yes, you'll notice some vaginal bleeding coming up, especially when you get up the first time to go to the bathroom. You may pass a couple of blood clots. That's because I just made an incision and I leave a gap for the blood to drain out. It'll get lighter and then it'll eventually subside over the next few days. There is minimal pain or discomfort. Now, you may have some leg numbness initially from the local, but it wears off soon. The voiding pattern, the nurses will call me and make sure that you're emptying. And once it looks that you're emptying well, I'll send you home, or we'll keep watching. You may go home with ibuprofen for some discomfort, just take over-the-counter Motrin. You may have slight bleeding, as I mentioned. Now, one thing you will surely notice is that your urine stream will become slower. It won't be like a weak urethra, just going to pour out the urine. It's going to fall out. There's no falling out anymore. The sling is sitting nice and good, so the stream will be slower as the urethra is well supported. You will be able to empty, but the stream will be slower. In fact, a slower stream tells you that it is working. Activity-wise, return to all activities. Now, just don't go crazy and go jumping up and down, but you can return to all activities, walking, going somewhere, no problems. Just listen to your body. Only thing you cannot do is anything in the vagina. That is because of a different reason. It's not the sling, it is that incision. You have a small incision in the vagina, you've got to let it heal completely. And that is why you have to allow 4 weeks, because you do not want him to go in and the incision rips open and now the sling gets exposed and we are in trouble. Now, despite what I've just told you, see how effective it is, how much it can be done under local. Sadly, women wait at least 5 to 7 years before seeking treatment. More women are wearing pads than seeking cure and feel that there is no treatment for stress incontinence. And they've heard all these horror stories of someone, maybe a mother or aunt, had bladder suspension and then concerns about sling in the media. They still remain enchained by stress incontinence. Now, it's about time that we say no to pads. There's really no need for pads at all. And just time to be dry, stay dry. Just like her, jump up, be happy, sound of running water, no issues. Bottom line, stress incontinence is very common. Affects at least 1 in 3 women, especially the young and active. In our hands, almost 100% success means cure, almost 0% complications. Local anesthesia, women have almost no pain and can return to all activities the next day. So what is the most common regret of our patients? I wish someone had told me about this earlier. So why wait? Get your life back, do what you enjoy doing, and stop suffering in silence and say no to pads. This is the game changer, as can be seen here. What's next? Well, if the sling works well for me, the patient asked me, is it one and done? Am I done? Will I be dry for life? Will the sling last? Can't anything go wrong? Now, in the next section, I'm going to tell you the importance of after sling care and what you must do. Thank you.